I'm delighted to have today's speaker, Demetre Daskalakis, is Assistant Commissioner of Public Health over at the Bureau of HIV and AIDS Prevention and Control for New York City's Department of Health and Mental Hygiene. And prior to working there, in September 2014, he was the medical director here at Mount Sinai's ambulatory HIV service and was associate professor at the Icahn School of Medicine. Outside of his clinical work, he also founded the Men's Sexual Health Project, which provided field-based HIV testing to the highest-risk men in New York City, attending sex clubs and bathhouses and places where people were at high risk. He also developed a program called Project 36 Hours, a post-exposure prophylaxis program that efficiently delivered preventive health and preventive interventions to men exposed to HIV. He's both locally and nationally renowned for his work in providing a meningitis vaccination during the outbreak in New York City in 2013 among gay and bisexual men. And this effort combined resources from Bellevue Hospital, the Gay Men's Health Crisis, Department of Health and Mental Hygiene. And in 2013, he was featured as one of Out Magazine's 100 Most Compelling People of the Year. Compelling. I love that. He also serves as the Antiviral Advisory Committee of the United States Food and Drug Administration. He received his medical degree at NYU, my alma mater, so you know he's good, and completed his training at Beth Israel Deaconess and Medical Center in Boston, and his fellowship in infectious disease at Partners in Boston. And in 2012, he earned a master's in public health from Harvard. Today he's going to speak about pre-exposure prophylaxis, an emerging topic for us. And you know, I've come to discover that this is a really interesting challenge for those of us in primary care. There's some interesting ethical dilemmas, really in how we handle people who are at risk for exposure and putting people on medication preventatively. In addition to some of the financial challenges, as this is a new indication for this drug. In closing, I would just say that we share a couple of things in common. We're both bald, and the other thing is he has an incredible amount of energy. I've met him in the last few minutes, and you'll thoroughly enjoy this talk. Thank you for coming.
Thank you. Bald and handsome is that's important. So thank you, everybody. So I'm going to sort of use my compelling moniker to tell you that I'm going to be presenting data to you, and I'm going to be presenting guidelines, but mainly what I'm going to try to convince you of is that really you own PrEP, and that you have the power to prevent HIV infection, especially in the setting of community-level primary care, which is really where it should be housed, in my opinion. So I have no financial affiliations to disclose, and what we're going to do today is talk about ways that you can identify people who may benefit from pre-exposure prophylaxis as an intervention to prevent HIV, help you make better decisions about PrEP initiation, and then even talk a little bit about some of the new data about PrEP use in episodic risk or PrEP on demand, which I will reveal to you our New York City guidance on that. And also help you identify at least the beginning of a clinical strategy that lets you actually do PrEP in your day-to-day practice. So it's important to figure out how to integrate that in. So I start really by having a series of cases, mainly with rhetorical questions, but if you're really excited, you're welcome to just scream out your answer. So I start with the story of a 27-year-old man who visits his primary care practitioner to discuss his risk for HIV infection. The patient reveals that he engages in behaviors that place him at high risk for acquisition of HIV and of sexually transmitted infections. He confides to his practitioner that he sometimes engages in condomless anal sex with other men, often anonymously and in the context of drug use. He's received 3 courses of non-occupational post-exposure prophylaxis. So just a little description. PrEP is a way to take a medicine every day to prevent HIV. it kind of takes the emergency out of the story. It's based on risk. Post-exposure prophylaxis is an emergency intervention. Something happens and the clock starts ticking and you have 36 to 72 hours to start medicines that prevent HIV. So he did that 3 times already in the last year. And has also been diagnosed with rectal lymphogranuloma venereum 2 months ago, and then just a few weeks before that, got a diagnosis of gonorrhea. So the patient asked his practitioner about the possibility of starting PrEP. He'd heard in the news that he could take a pill every day that could really lower his risk of HIV infection. So my first rhetorical question is he a candidate for pre-exposure prophylaxis? And enthusiastic nods from the audience. This is not a made-up story. That's an important sort of moment here. So let's actually unpack that a little bit to talk about why he's at risk. Obviously, we have a couple of red flags, and I want you to recognize those red flags since they're so important. But we'll take a quick aside and say one of the red flags, which is rectal sexually transmitted infections, if a tree falls in a forest and there's no one there to hear it, does it make a noise? If you don't screen for rectal STIs, you're not going to find a rectal STI. So that's an important first step. So think about in men who have sex with men, 3-site screening for sexually transmitted infections. So looking at San Francisco data, what they did was they looked at people who had multiple rectal infections and whether or not they seroconverted in the next year or so, or years after their rectal infections. And what they found was that individuals who had 2 or more rectal infections had a significant rate, almost 8-fold higher rate of acquiring HIV. The bad news is that even 1 rectal infection led to an incidence of 15 per 100 person years of HIV in that cohort as well. So this rectal infection flag is your first flag in this individual. I will then take that San Francisco data and show you the New York City version of it, which is looking at rectal STIs and HIV acquisition. And this time, in New York, they just looked at 1 rectal infection. And again, rectal infection was a really significant marker, as you can see here, for HIV acquisition. The incidence was 6.67 annually, compared to the not so low 2.53% in men without. The other important lesson in the New York data is Black men were about 5 times more likely to get HIV, whether they had a rectal infection or not. And that has more to do about the prevalence rather than behavior per se in that population. So it's important to remember that Black men who have sex with men are at specific risk given the fact that there's a lot of HIV in that community. So that's your first red flag. The second is the post-exposure prophylaxis. So there are 2 studies from Amsterdam that showed that people don't seroconvert after post-exposure prophylaxis immediately or during the med. The med works, people adhere, things go well, but 3 to 6 months out, many people will seroconvert. Why is that? Is it because the meds failed? No. It's because the behaviors that led them to post-exposure prophylaxis persist. So when you see someone with a rectal STI, when you see someone who has had a course of post-exposure prophylaxis, that is a red flag that in your mind should say, I need to talk to this person about their risk and I need to consider starting a prophylactic medicine to prevent HIV. So that actually leads to the New York State guidelines of who needs to start antiretrovirals for prevention. So let me highlight a couple of important things. So men who have sex with men who engage in condomless anal intercourse are way up there. Individuals in serodiscordant or serodifferent partnerships where one partner is negative and one partner is positive is important. Trans people who are at sexual risk, individuals who engage in transactional sex. But I want to highlight one really important one that makes us so much cooler than the CDC in terms of risk, which is injection drug users, but not only injection drug users, but people who use stimulant drugs associated with high risk. What does that mean? Methamphetamine, crack cocaine. So if you have people who are at enhanced behavioral risk for HIV acquisition and they're meth users or they're crack users or using stimulants, that should trigger a conversation about risk. Injection drug users, that's also a slam dunk, and I'll show you that data. I just am highlighting how that data that I showed translated into guidance with sexually transmitted infections, more than one anogenital, or individuals who had PEP are independent indications for starting PrEP. So I think that that's a really important thing to remember, that they're red flags, and some of them aren't necessarily red flags around sex, but around other behaviors. So this is part 2 of that case. The provider that the patient was seeing was unsure of using tenofovir emtricitabine, which is the drug that's approved for pre-exposure prophylaxis. He'd never prescribed the drug before and was not comfortable with the revelations of condomless sex that the patient had provided. So he guided the patient away from PrEP, but offered a referral, an unnecessary referral, to an HIV specialist to discuss this intervention further. He was uncomfortable with providing PrEP because he didn't want to give the patient the message that he was condoning condomless sex, and was doubtful that it was an intervention that could have an impact in his practice when compared to other things he prescribes every day, like statins, to prevent cardiovascular disease. So is the provider right to guide the patient away from PrEP? I feel you want to say no. And so I sort of start by showing you why some of this is happening. So this is my montage slide of all of the give and take, all of the theoretical debate about pre-exposure prophylaxis. So this is one of my favorites. So this one looks like I produced it at the Department of Health, yeah? It says why I'm a liar and tries to say that PrEP does not have an evidence base to actually have people on it. So in fact, it's an ad that was taken out that said there's doubt that we shouldn't do it. Meanwhile, you will leave the room with no doubt by the time I'm done with you. There are people who said that people who are taking pre-exposure prophylaxis to prevent HIV infection are cowards. There are people who are on the other side saying, we're going to do this and reduce HIV infection. And there are other people who just had their tongue firmly in their cheek, but may accidentally be creating a stigma duality where they're saying, we're going to reclaim the fact that just like birth control when it launched in the 60s, we're not going to be shamed for our behavior. We're just preventing an outcome that we don't want. So there's a lot of tension, a lot of back and forth, but ultimately, I want to sort of give you a model of preventing infection that really, I think, stimulates the conversation of why PrEP is a good idea. So from my perspective, I can identify two models for how to prevent infections using medicines, or not. Here's the first model of prevention. So we have a lot of experience in preventing malaria using prophylactic medicine. So if you travel somewhere, medicines are potentially an option. So one model for preventing malaria is that when you travel to parts of the world where you can get malaria, you should always use bed nets, avoid mosquito exposure, and don't leave your hotel, or else I'm going to judge you because you're going to get malaria. So HIV, when you're in a behavioral or epidemiologic environment where HIV risk is high, what can you do? So it's true, you should always use condoms if you can, always, for sex, all the time. Have one partner, and don't, whatever you do, have an HIV positive partner, or I'll judge you. So there's model two. And model two is when you travel to parts of the world where you can get malaria, what do? You use your bed nets, you avoid mosquitoes as much as possible, but if you choose to leave your hotel every now and then to see what you're traveling for, you should take anti-malarial medicines to prevent acquisition of malaria. That's PrEP malaria, pre-exposure prophylaxis. So I extend that model to HIV, that if you are in a zone, a time when you're at behavioral or epidemiologic risk for HIV, what can you do? The answer is try to use condoms as much as you can. But the reality is that sometimes people won't or can't do this. So if you want to prevent HIV, kind of like the way that we prevented HIV in injection drug users by providing clean syringes, if you want to prevent HIV, you can reduce harm by using HIV medication to prevent acquisition. So this is my data montage. I'm literally going to tell you all the studies at once and really try to convince you that there are data that have led to very strong guidance and guidelines to support the use of tenofovir emtricitabine for pre-exposure prophylaxis. So this is the Partners PrEP study. So this is your MPH drill of looking at survival analysis. You're going to look at all of them at once, and you're going to see they say the same thing. So on the y-axis is cumulative acquired HIV. On the x-axis is months since start. In this one, this dotted line are people on placebo, and these lines are people who are on one sort of PrEP or another. So the lesson in this one is that there is a nice big gap between placebo and people actually on active drug, because the people on active drug didn't get HIV as much. On the order of about 70% in this study did not risk reduction of HIV acquisition. This study was in heterosexual couples. This is the iPrEx study. And iPrEx was an evaluation that happened in men who have sex with men, mainly, well, in the US and parts of Latin America. And again, back to your MPH, it's survival analysis. The red line is placebo. The blue line is drug. 44% risk reduction in HIV acquisition in this population. So we're going to delve into this 44% in a moment, where you can say to me, 44% is not so super, realizing that nothing prevents HIV, like anything that's close to 44%. If a vaccine hit 44% for HIV, it would be licensed. So it's kind of a big deal, but we're going to unpack that further. This is the data from something called TDF2. I'm lying. This is the data from the Bangkok injection drug user study. So this was a study of injection drug users at risk for HIV in Thailand. And again, blue line is placebo. This time red line is drug. Risk reduction on the order of about 60%. This is TDF2. This is people who were in Africa who were at behavioral risk for HIV, who were on tenofovir emtricitabine. This time green line is placebo, red line is drug. Risk reduction for HIV acquisition. This one somewhere around 65% as well. So your overview of the data for the positive studies is this, but let's talk about the negative studies. There are two, PrEP and Voice. These are studies that happen in women in Africa. And the studies had one thing in common, which I'm going to reveal to you, which is that in their design, there was not enough support for adherence with a population that really didn't necessarily want to take a pill a day. And so the study didn't fail because the drug failed. The study failed because the drug never got into someone's body. And so that you'll see is an important theme. We're going to get there in a second, but first I want to talk about this idea of, is it worth taking a medicine once a day to prevent HIV if you're perfectly healthy? Well, I go back to the statin story. So let me orient you to this kind of complicated but really pretty slide. On the y-axis is a number of people needed to treat in a year to prevent an event. On the x-axis is the number of events in a study. So we have a bunch of studies here. So iPrEx, I showed you that data, Partners, Bangkok injection drug user study, that's all here. What you'll see is that there's a significant event rate in some of the studies. So a couple of events per 100-person year, about 4 events per 100-person year in some of them. And when you look, it takes about, at least in these studies, somewhere between 50 and 100 people to treat to prevent one event. Up here is your friend the statin that you use every day to prevent cardiovascular events. In primary prevention, technically from the perspective of the efficiency of the intervention, PrEP is a more efficient intervention for people at risk than our statins. There is a cost difference, for sure. But from the perspective of prevention, it's high. Some of the more recent studies, more real world, actually show that the number needed to treat in really high risk groups may be as low as 6. And then all of a sudden, the cost effectiveness shoots up. And just like prevention with statins, prevention with Truvada or tenofovir emtricitabine for HIV acquisition seems to make both financial sense for some populations, as well as sense for why one would take a pill once a day. So let's get into the weeds a little bit about why that iPrEx study, why that study in gay men only showed about 44% risk reduction. They did a case control study embedded in that iPrEx study, and they looked at people who were supposed to be on the drug arm and got HIV, and compared them to people who were supposed to be on the drug arm who did not get HIV, and they measured drug level. What they found is that there was not much drug in the people who got HIV, but the people who did not get HIV actually had detectable levels of drug in their body. So that's important, detectable levels of drug, not even therapeutic levels, detectable. So for having a detectable level of drug, there was a 92% reduction in HIV acquisition. Now that's better than your flu shot. That's pretty amazing. And so when you look at the story across all of the studies, Partners PrEP, TDF2, iPrEx, and PrEP, there's one thing that becomes clear. There's a linear relationship between adherence to the medicine, having it in your body, and what it does to prevent HIV. So here's PrEP, which is the study that failed. Only 26% of people in that study even had drug in their body. So it's not measuring the drug, it's measuring adherence, which is still a really important thing, especially when you look at other people who can support PrEP in a practice. On the other hand, studies with high levels of adherence did great. And so then really smart people did another thing, which is they looked at a drug study, a pharmacokinetic study, where they said, what happens if I give someone 1 pill of tenofovir emtricitabine a week, 2, 3, 4, 5, 6, 7, and they figured out what the levels were like. And then what the smart people did is they took that study in healthy individuals and overlapped it to the iPrEx data to see about how many doses of this pill you have to take a week to yield protection. And so this is the graph of this. And what they found was that even with imperfect adherence, based on the drug levels found in the study, if someone took 4+ tablets a week, they would have approximately somewhere in the high 90s to 100% prevention of HIV acquisition. Nothing is 100%. You can always challenge, you can always find a way to overcome 100%. But the point is that if you're taking the medicine even a little, even like moderate adherence, you actually see an impact. And one of the comments that we always hear is, do people have higher risk sex after they start PrEP? So these are data from iPrEx. I'm going to have you completely ignore that. I'm going to totally leak data from San Francisco because they just shared it. It's not public yet, so I'm not going to tell you its source. But in a cohort of a demonstration project, they found that about 65% of people who started PrEP stayed exactly as they were for risk, which was at risk. So they were not using condoms consistently. That's why they're on PrEP. About half of the people who did not change increased condom use, and a half of the people who did change decreased condom use, but they were on PrEP. And so there was a shift in behavior, but at least in the demonstration project's initial data, it's unclear what direction that shift is in. So one of the things that I always say is that before we worry about getting PrEP into people's bodies and adherence in New York City, we need to worry about getting it into their heads and their hands, because people don't know very much about it, and it's apparently there's barriers to getting it. And so what my job here today, aside from telling you about this data, is to convince you that facilitating access to this drug may actually change the epidemic in our city and our state. So flash back to the slide of people who are debating PrEP, that this is an intervention that one has to debate. These New York State guidelines say that you don't have to really have any controversy about it because it's the guidelines in the state to do this. And if that's not good enough, here are the CDC guidelines that say that people who are at risk should get pre-exposure prophylaxis. So really, I sort of like to stand here and tell you that the debate is over, and that really rolling out PrEP to the appropriate population is critical. And I'm going to back that up with the governor. And so our New York State governor just recently released a blueprint to end the epidemic in New York State. When you hear ending the epidemic in New York State, you should look at me and be sad, because that's 80% is in New York City. So they're kind of saying, Demetre and your team, let's make this happen. So these are the pillars that the governor wants us to focus on to end the epidemic. Okay, test more people, test everybody. Like, that's the theme. So keep doing it, because I know you guys are definitely ahead of the curve on that. Link and retain people to HIV care and get them their viral load suppressed, because if you do, you prevent HIV transmission. And the really edgy step that no one expected is, he said, use pre-exposure prophylaxis to prevent HIV acquisition. So a lot of the naysayers, people are cowards, we shouldn't do this. Guidelines say, governor says, we say, we're pumping it out throughout the city and hopefully throughout the state. The New York State actually has an assistance program to provide PrEP for people who are uninsured and undocumented, at least the care, and then other ways to work around getting the drug. So one of the challenges in New York is, when I see this ending the epidemic story, I look at it, and this is at least the first pass of what I see, which is given that 70% of the new infections in New York are among men who have sex with men, I see that we have to sort of focus on this priority population. But I'm gonna up the ante for you and say that this is only the partial reality. What it really means is that LGBTQ youth of color and other men and women not served by healthcare need to be given access to testing, HIV treatment, and ultimately, if they qualify, for PrEP. And so it's really our challenge and our duty to our population that experiences a healthcare disparity every day to prevent HIV morbidity by treatment and HIV itself and those at risk. Because that HIV test opens a door that's a lot different than it used to. A positive test used to be the way to get to care. Now a negative test is a way to get into care. And that's really what we're gonna strike home at the end. So one more time, there is no debate. So I really encourage you to sort of think about this and take it. Just like you use new antihypertensives, just like you'll use a new drug for diabetes, tenofovir emtricitabine is a new drug in your armamentarium to prevent HIV acquisition, and the only way to figure out how to use it is to do it. And like my colleague said in LA, PrEP is easy compared to other stuff, and as we said this morning, it's a lot easier than hypertension. So much easier. So back to case one. So he went to an HIV specialist, that's me, and decided that this intervention was potentially good for him, as well as other ideas to sort of prevent STIs, including using condoms as often as possible. One of the important things about PrEP that we don't talk about is that not only is PrEP HIV prevention, it's prevention of acute HIV. So the people who get HIV through sexual transmission or through needle sharing, they have a phase during their infection where they're highly infectious. It's the phase of acute HIV. By preventing HIV and preventing acute HIV in these individuals who have the behavioral risk of transmission, you may be knocking out a part of this infection history that may prevent forward transmission, realizing that in studies, over 50% of new HIV infections are caused by someone who's acutely infected. So if there's less acute infection, there may be less HIV transmission. So there's a hidden benefit that it's not only about HIV prevention, but also about the time of HIV prevention. So this person reported that he had had condomless receptive anal sex with an HIV status unknown partner 3 weeks ago. So what are the next steps to initiate PrEP in this patient? This is the part where I teach you that PrEP is easy compared to other stuff that you do. So there's some education. This can be something that you can hand out. So you have to talk to them a little bit about PrEP, talk to them about the limits, and one of the important messages is that it doesn't prevent STIs. So you can prevent HIV, but you need to have vigilance for STIs. A little nugget of information. In one of the demonstration projects in London, this is where I'm going to have a little crowd interaction. What percentage of people who came for a PrEP intervention at baseline had a positive result for a sexually transmitted infection? Is it 10, 20, 30, or 40%? It was about 40%. So they started off with STIs. So will PrEP potentially lead to STIs? Probably. There may be more transmission, but guess what? These folks have never been screened correctly for STIs in their life. And so there are some data in projects that as you screen for STIs, the rate of STI goes down. So it's going to be an interesting thing to sort of see how it plays out, that this potentially could increase STI rates, but it is a harm reduction intervention. So it's important to talk about that from the education perspective. And then a couple of pre-prescription assessment ideas, which is to talk about acute HIV infection. So if you have a fever, if you have a rash, if you have a sore throat, make sure that we know about it, because you do not want to start PrEP during acute HIV infection, because the only time resistance really has been seen in studies is people who start PrEP during their acute infection when the antibody test would be positive, and you'll have the false sense of confidence that it's okay. It may not be. So symptoms are one big flag. And I'm going to talk to you a little bit about some additional testing that you may need to do depending on what your test is, but we're going to get there in a second. So there are other important things about HIV, which is it's not just about sex. There are other drivers that lead to infection. So screening for domestic violence, assessing housing status, and seeing really if PrEP is something they can pay for, or if there's a mechanism to cover the drug is really critical. I also just barely spoke about this, but it's important to talk to women and others with fertility goals about the reality that it is adding a drug into their body that has good evidence as being safe in the setting of conceiving children, but it's important to sort of have the conversation and realize that these guidelines actually encourage the use of PrEP in women who are seeking to get pregnant if they're in a serodifferent partnership. So one of the little takeaways is that there's some lab work you have to do. And so the most important piece of lab work on the planet is the HIV test. Do not start PrEP in someone without an HIV test, and do not start someone who has potentially symptoms of acute HIV infection. Additionally, the New York State guidelines say that if you have someone who's had condomless sex with an HIV-infected partner in the last month, you may have to look for acute HIV through a screening test. Good news is that soon at Mount Sinai, you'll be moving on to your 4th-generation HIV test that combines antibody and antigen, and so it's one-stop shopping. In the interim, if you're concerned, you'll have to send an off-label viral load to do the same screening. But that's something that's acceptable to most people. So beyond screening for HIV, there's a basic metabolic panel, because one of the only contraindications to PrEP is having a creatinine clearance less than 60. A urinalysis is a baseline, because one of the drugs, tenofovir, can cause a Fanconi's-like syndrome. So it's important to screen baseline what proteinuria and normoglycemic glycosuria, if that's present, to know what's happening from the perspective of that drug. Serologies for Hep A, B, and C, screening for sexually transmitted infections, ideally in 3 sites for gonorrhea and chlamydia for folks at risk, and syphilis, since that is definitely on the rise, and a pregnancy test in women. So that is your baseline lab evaluation. Not too hard. So then what do you do for prescribing? Well, there's only one drug approved for PrEP, unlike the number of drugs you have to deal with hypertension. Only one. And that's tenofovir emtricitabine. And the state guidelines, I think, are great, which is to give them a 30-day supply of the drug and then have them come back to make sure things are okay, and then give them another 2 months, and then they come back every 3 months. And what happens in those 3-month visits is HIV testing, risk counseling, condom distribution, and if needed, screening for sexually transmitted infections, and I am beating you over the head with it at 3 sites for people at risk. So really important to think about that. So, yes?
Quick question. For your 3-site screening for GC chlamydia,
Yes.
are you doing a culture or a nucleic acid amplification? Our labs will sometimes not run like a pharyngeal swab for gnats because it stays off label.
So it's actually also controversial whether you're going to screen for chlamydia or not. So ideally, the lab now, I've heard rumors, now lets you send a rectal gnat officially.
Okay.
Yeah. If not, it's coming because it's validated. It's just a matter of time. So I tend to do a gonorrhea swab of the throat, and then I do a urine and rectal gnat. It would be great to get the oropharyngeal gnat validated. I actually worked to get the rectal gnat validated here before I left, so it should be set. And the truth is, and again, another off-label moment is, a lot of people do send it off-label. Quest and LabCorp have it validated and will have it reported out as rectal or urine. But definitely that's the guidance is that, and I think the labs are chasing that down, making sure I'm not super crazy late. Good, no, I'm good. So again, we'll just go through the visits just to tell you what it looks like and to really show you that it's not much of a heavy lift. So after they start PrEP, they come for a 30-day visit. They get a side effect check. They do not get tested for HIV at that visit, unnecessary. What they do get is a creatinine screen, just to make sure that tenofovir didn't make their kidneys go bananas. And also at every visit, risk reduction and condom distribution should happen. If you don't have condoms, there's a wonderful app, New York City condom app. You can talk about your folks. We'll send you the king size ones, whatever you want. We will cover your clinic in latex. So if there's a shortage of supply, we're definitely able to take care of you. After that 30-day visit, they come again in 3 months. They have an HIV test. So they say in the guidelines to ask about STI symptoms. I like to test. I like to offer testing as much as I can because you'll pick up things. A serum creatinine happens again. And then pretty much you go into this zone of HIV testing, STI screen, and then once every 6 months you check their creatinine, and once a year you check a urinalysis. And ahead of the time, before the new CDC STD guidelines come out, recommended of annual Hep C screening in men who have sex with men and IDU. So the new guidelines that are going to come out from the CDC include annual screening. I don't know what the yield is of that. My experience has been that that will be a pretty low yield, but the guidance is changing. So there's some recent data that I want to talk about. If you are steeped in the PrEP universe, you may have heard about a couple of studies. One is called iPrEx, which is a study, it's French, so they're funny. So what they did is they said, what if people don't want to be on a medicine once a day? Are there alternative strategies for dosing PrEP? And what they said was, let's try this. And it was based on a monkey model. It wasn't out of the blue. Like macaques did this and it worked in macaques. It's 2 doses of PrEP before 2 to 24 hours before sex. Then the little heart, which I think means sex. And then a dose of PrEP a day for 2 days after. Their other idea is, let's say that another heart appeared somewhere here, you just extend another 2 days. So that was the idea of iPrEx, event-driven PrEP. So a couple of things. So in this population, they actually stopped the study early. There was an 86% reduction in HIV acquisition in people who were on PrEP versus placebo. Adherence was good. Their safety was on demand. They didn't see was good. They didn't see any evidence of risk compensation. So their conclusion was, this is a great intervention. So no, I don't think so. So let's talk about why intermittent PrEP may not be a good intervention. It's all about the details of the study. Do you remember the slide I showed you about how many times a week you'd have to take pre-exposure prophylaxis to prevent HIV, right? It was about 4 times a week. 4 times 4 is 16. So if you took it 16 times a week, you'd expect that you would have a almost 100% reduction in HIV acquisition. Bottom line is that this is a really impossible study to design because what they should have been looking for is people who are moderately sexually active. But they found a group of people who were very sexually active. So they were taking PrEP about 4 times a week based on their sexual activity. So that's 16 times a week, which means that what they measured was intermittent PrEP. They didn't measure on demand. So then there's the other thing that really got me to write this on the New York City website about PrEP and send out to our providers. 60% of sexual encounters involve the incorrect use of PrEP. So what happened is, the magic about PrEP is it's not an emergency. And as my friend Sarit Gollum says from CUNY, it disassociates the act of HIV prevention from the act of sex. Condoms, on the other hand, it's associated with the act of sex. On-demand PrEP, associated with the act of sex. You have to say, I'm making a decision. And 60% of people made the wrong decision and didn't start it. And so it seems as if this may be an intervention for some people, but definitely not the baseline intervention for all. Better to sort of uncouple the act of prevention from the act of sex. And so we recommended in a pretty strong comment that daily PrEP should be what we encourage for our population. And then this is something I'm going to show you mainly because we're going to do the same thing in New York City, which is the PROUD data from London. And so STD clinics started PrEP. They did a little bit differently because they did the longitudinal follow-up as well. We're not going to do that. We're going to be sending them to you for care. So we're going to be doing some of the starts. But what they did is they either put people on risk reduction and Truvada, or gave them some risk reduction and started Truvada about 12 months later. And then they were followed up for 3 months. So start right away or start a little later after some other counseling. And what they found was an 86% reduction, that's the magic number, in HIV acquisition in people who started sooner than later, an extraordinarily high incidence rate in those who waited, and the fact that it was 100% acceptable in the setting of a clinic, especially in a busy STD environment. So it actually worked out really well. And so the PROUD study doesn't tell us very much except that as a piece of implementation science, PrEP is scalable and can be done in a clinic. So we're to another case to add some spice to the story, which is what happens when you bring treatment as prevention into the mix. This is my second case of an HIV negative man who's in a monogamous relationship with his HIV positive husband. The positive partner has T cells of about 700 and a viral load that has been undetectable for the last several years. The negative partner is tired of using condoms when he's insertive, but he uses condoms for all anal sex when he's the receptive partner. So he has his own prevention strategy embedded. He comes to you asking if he needs to be on PrEP. So in the case of a monogamous serodiscordant relationship, MSM or otherwise, is PrEP indicated given the decrease in transmission associated with treatment as prevention and viral suppression? So how does treatment as prevention and PrEP, how do they fit in the toolbox? And so one of my consistent assistant commissioner statements is that New York City is going to be focusing on data, not dogma, for HIV prevention. So I'm going to show you the data, and then we can talk about what the right thing may be, because I think there are a couple of answers. So HPTN 052, who's heard of the study with this catchy name? Right on, excellent. It's such a bad, it doesn't really tell you anything. 052 was a game changer. What they did is they recruited about 1,800 couples, serodiscordant, one positive, one negative, mainly heterosexual. And they then started the HIV positive partner on HIV medicines independent of their T cells and viral load. That's the intervention arm. The control arm was they waited for them to either have a low T cell count or to get sick for some reason. And what they did was look forward not only at endpoints in the people living with HIV, but ask the question, does earlier treatment prevent HIV transmission? And what they found was that there were 39 transmission events. 28 of them were linked, which means that the sequence of the viruses were the same. Footnote, that means that 11 weren't, and that means that that was a transmission outside of the primary relationship. That's a completely different conversation, again, focusing on sort of potentially the role of PrEP. So, of the linked transmissions that had viral, they were homogeneous from that were similar virally, there was 1 in the immediate arm and 27 in the delayed. Well, so the immediate arm 1 has a little story attached to it. The positive partner was not undetectable yet at the time of that transmission. So it has to be reported in the immediate arm, but it had not yet been achieved. So in this study, there was a 96% reduction in HIV acquisition based only on the fact that the HIV positive partner was undetectable. So the next stage is the partner study. And in this one, they actually recruited serodifferent partners who have condomless sex and who are not on any kind of chemoprophylaxis. So that means the negative partner is not on PrEP, but the positive partner, that person had to be undetectable. And the first question they asked them was, how much condomless sex are you having? And what they found was that almost 100% of the heterosexual partnerships had condomless sex, and that there was a little, some variability among men who have sex with men, but there was a fair amount of receptive anal sex and insertive anal sex happening. So they followed this cohort forward, and this is just preliminary data, and what they found was that there were 0 HIV transmissions in any population. Vaginal sex, anal sex, so 0. But it's important to remember that there's a confidence interval associated with any finding. And so it's plus or minus 4%, right? So it's 0, or actually plus, there's no such thing as minus. So it's 0 with a confidence interval. So as far as we can tell, HIV treatment as prevention works, and that's also evidenced by the fact that in New York City, our rate of HIV infection, our new infections in the last, from 2003 to now, have gone from 10,000 to 2,800, and it's not because of condoms, and it's not because of PrEP, it's because treatment prevents HIV transmission. And so our curve is bending on the back of treatment as prevention. So the partner studies And HPTN 052 says that HIV treatment itself prevents HIV acquisition. So where does PrEP fit? I'm going to take a little aside here. I didn't add a slide, which I should have, which is there's an interesting study going on now that's part 2 of Partners PrEP. And what they're doing is they're using PrEP to TASP. So they're using PrEP to lead to treatment as prevention. So they have 2 partners, one with HIV and one without. The HIV negative partner starts PrEP. The HIV positive partner starts treatment. They continue on treatment and PrEP until around month 6 or 7 when the HIV positive person is undetectable. When they're undetectable, the negative partner drops the PrEP. So that may be the future. The preliminary data presented in March was that there was a 96% reduction in HIV acquisition using that strategy. The study's too young. It's mainly on the back of PrEP. So when we go further out another year or 2, we'll actually know if the strategy of temporary PrEP leading to treatment may be the right answer. So where does PrEP fit in this? It all depends on what the patient wants. It's really about discussing risk and do you want to have suspenders or do you want to have a belt and suspenders? It's ultimately a discussion between provider and patient and is very, very individualized. Case number 3, a 23-year-old black male presents to your practice to be treated for syphilis. Okay, one more audience participation moment. How many times does your risk for HIV in New York City increase if you've been diagnosed with syphilis and you're an MSM? Is it 2-fold? Is it 3-fold? Is it 4-fold? Is it 6-fold? It's 6-fold. So syphilis, it's a big red flag that says you should start PrEP or think about starting PrEP. So the patient, however, says that he's straight, but sometimes has sex with other straight men. He does not use a condom for anal sex because he states that his older partners prefer raw sex. So this is one of the challenges that you see in clinic, which is you're up against someone who is at risk, but all of a sudden we have this intervention that gets boxed into this place where it's a gay drug, which actually happens to women all the time who are in serodiscordant partnerships. The number that you'll meet who say, I went to the doctor and they said, this is for gay men only. It's not. It's for people who are at risk for HIV. So you approach him about PrEP and he states that he does not think he needs it. He thinks it's good for gay guys, but not for him. And that he's not a, quote, Truvada whore. And that he thinks that men who use PrEP are all bottoms. Literally, I have thrown all of the stigma in one sentence around PrEP in this population, which is not only is it a question of being gay, but it's a question of this is an intervention for a receptive partner, and that's not okay in my community. So we're up against a lot there. So what are the barriers to implementation? So one of the things I like to think about is, do they know their own risk? And so this comes right out of the bathhouse studies that we did. Hi, Richard Silvera. So we created a survey question focusing on self-perception of risk and willingness to start to take PrEP. And we asked 500 guys about this. We prospectively administered a survey and said, do you think that you're at risk for PrEP based on your behavior? Are you a PrEP candidate? And then what we did is we used the criteria for iPrEx, which is the study that led to the approval of the drug. That's the study among men who have sex with men, to see if they would have been candidates for the study. And then we compared that to their self-perception. And so this is what we found. So of the guys that we interviewed, about 73% of them met iPrEx entry criteria. So they would have been in that study that led to the licensure of the drug. And actually are pretty much aligned with the New York State guidelines for starting meds as well. But only 78% of them, actually only 22% of them thought that they were risky enough to start PrEP. That means nearly 80% of them thought that that was a great intervention for Joseph or Sally, but not for me. And so that's what you're up against in risk assessment when you meet people in the clinic, which is not only do you have to talk about PrEP as an intervention and deal with stigma, but you also have to deal with the fact that people don't like to be categorized as risky and don't see themselves as risky. So really the frame is one of sexual health, which is that you have the power, a tool beyond condoms that you can use along with condoms to prevent HIV is PrEP. And having a frank conversation exploring sexual activity is important, because the other thing that's significant to remember is that in most studies, and in New York City studies show that only about 60% of men who have sex with men disclose this behavior to their providers. So this is an important opportunity. Do you ask people about smoking? Yes. You ask them about that to prevent, to sort of risk reduce them for cardiovascular and other complications, asking a sexual history becomes a very important screening test because you can prevent HIV and save the system hundreds and hundreds of thousands, if not millions of dollars by doing it, as well as complications for a patient. So this is what New York City has started to do, and boy, is there more coming. We have done a small social media campaign around PrEP and PEP. Coming this fall, you're going to go on the subway and see a PrEP ad, and it's going to feature women and men and trans people, and it's going to be about combination prevention, both bringing condoms to the table in the context of other preventative interventions. So we're really starting to get the word out to people about PrEP, and I'm going to share some unpublished data from New York City that will show you that it's starting to work. One of my favorite things that we did is that we took a page out of the corporate pharma's playbook and created a action detailing kit. And what we did is we took all the important stuff about PrEP and made this nice little booklet, information for patients, information for providers, billing codes, all of the stuff that you would need. And we put it into this nice little glossy thing that it looks like a drug company made. And then we hired drug reps. And those drug reps went to 900 providers to teach them about PrEP. 900. And we're going to do more of it. And what we're seeing, at least in the feedback, is that the number of PrEP prescriptions amongst the providers that were detailed doubled. So they're more likely to prescribe. And even more exciting, they doubled the amount of conversations they had about sexual history taking. So that's really exciting as well. Because the detailing kit isn't just about drugs, it's also about how to create the environment that you can have this conversation. So this is a picture of folks at the Stapleton STD clinic in Staten Island. I did a just random visit to them because I was in the neighborhood for other reasons. And true enough, they were sitting there looking at this saying we should start doing it. They will be doing it. It's pretty exciting. They were awesome. In terms of awareness of PrEP, we're starting to see in New York City, in our sexual health survey, increases in people aware of PrEP. So that broke 50%. There is a little bit of a race differential, not statistically significant, but it looks like Black and Hispanic men may be a little bit less aware of PrEP than their white counterparts. But the bottom line is that PrEP use is really still hugging zero, although we're seeing the beginning of increased use, but it's really slow compared to what we'd like to see. So we recently distributed condoms and did other preventative work at this big event that could be seen as a place where men at risk would attend, called the Black Party, big circuit party in New York City. We actually got drink tickets from the Black Party as our, not alcoholic, as our incentives to people to stop and do a survey. So we got about 200 people to stop and talk to us. And what we found, though we haven't analyzed it, stratified it, because it's a small number, is, first of all, about 14% of the people who landed were HIV positive at baseline. We actually asked them about viral suppression, so we'll have that data soon. But this is the part that's important. As someone who used to do testing in bathhouses, I often feel that high-risk, people who are identified as high risk tend to be early adopters of preventive interventions. And so this is what we found. 90% of the people that we asked about PrEP knew about it at the Black Party. A third of them were on it. So if this is the sentinel beginning, my hope is that what we're seeing in this population will spread to folks who may be moderate and high risk, and we really see an increase in PrEP as a way to prevent HIV acquisition. So our ultimate goal in New York is to keep everyone in New York City undetectable, whether they're HIV negative or HIV positive. That duality really starts to fade away. People with HIV have a right to services and high quality of care that promotes viral load suppression. And the corollary to that is people at risk for HIV have the right to access prevention, so they don't get it. So when I think about the continuum of care in New York, this is what the future is. And so this is our classic continuum of people with HIV. So we have people with HIV, diagnosed or undiagnosed, a certain number of them linked to care, fewer of them are retained, fewer are started on antiretrovirals and fewer are suppressed, but the numbers are getting better and better every year and every day. But there's a problem with this cascade, a problem with this continuum, which is that it is only focusing on people living with HIV. And in fact, there's bars before the bars looking at people who are at risk for HIV. And really, when we do this, when we look at people at risk and actually see that PrEP is our opportunity to lead them to care, all of a sudden, this continuum becomes HIV neutral. And the care of a positive person and the care of a negative person looks identical. And that really is a first step at stigma busting, removing that duality in care and acknowledging that it's the care of people that we're showing on this continuum. That's our first step in changing the story of HIV in New York City. That's it. Thank you.
Back to, you had a slide earlier that talked about the effectiveness of PrEP versus the level of drug in the body. Other than just the typical adherence issues that we have with all of our medicines, are there specific things to Truvada that were identified as barriers to adherence?
Yeah, so the side effect profile of the drug is really good. And so it wasn't any kind of subtle side effect. It was about daily administration. And so definitely in the studies of women, this is actually a good aside. So in the studies that failed, PrEP and Voice, they both had something in common, which is that they were done in Africa, where the baseline level of care for HIV negative women wasn't very good. And so people were entering the study because they were able to access contraception and other services. And so they weren't taking the Truvada because they didn't want to take the Truvada. They just wanted the care attached to the interaction. So that, at least in women, was the reason for that. In the men who have sex with men, there were a lot of theories. Some of them, I think, are a little biased theory, which is that when you look at North American men in those studies, they were very adherent to the drug. There was less adherence in the men who were outside of North America. I don't know what that really means. It may be a differential in what's going on the counseling or on the advice that they were getting, but definitely the adherence issue is not around a side effect. Did that answer your question?
I think so.
Okay.
Hi, this is pretty exciting. So I just wanted
I
to.
agree.
Yeah, I wanted to ask. You mentioned syphilis, but like other STDs, like chlamydia has a high rate, especially in Harlem.
Yeah.
Like, is there anything like physiological to suggest that increases HIV?
Yeah, absolutely.
You didn't mention that.
Yeah, there's actually a lot of biologic evidence that gonorrhea, chlamydia less potentially, but gonorrhea and syphilis may increase risk for HIV from the perspective that the cells that you activate in response to those infections are also the cells that are the target for HIV infection. So CCR5 containing cells that are T cells. So they do increase risk for HIV acquisition. There was no differential in the studies of people's HIV rate based on their STD acquisition, probably because of PrEP. So the pre-exposure prophylaxis did prevent HIV acquisition, even in the setting of getting other STIs. Counseling-wise to patients, however, I talk about this all the time because your goal is to sort of blend PrEP with as much condom use as you can. And so every time someone uses a condom, they prevent HIV better, although PrEP is pretty good, but they also prevent gonorrhea, chlamydia, syphilis, and potentially Hep C. And so the guidance is not an all or like a one or none. It's a guidance of like somewhere there's a blend, which by the way is what the messaging is going to be in New York City soon, where there's like a blend of things that you can do and it's not just one thing. So it's not just condoms or just PrEP, it's some blend of the two. So your point's really good. STDs increase risk of HIV acquisition, but in the PrEP studies, they didn't actually.
When you're initiating PrEP, how restrictive are you in terms of like your assessment of the patient's ability to be adherent? So
Yeah.
if you, like, you know, you're not going to start hard on someone who you're pretty confident won't be adherent. Where do you
Well,
make that balance for PrEP?
So we're notoriously bad at knowing if people are going to be adherent or not. So one of the sort of historical things with HART is that there were many, many years where injection drug users were just undertreated. Now it's with Hep C, but undertreated with HIV medicines. So when you look at studies of injection drug users and people who you would potentially predict would not be adherent, they end up doing great. And so my feeling is that, you know, that the paternalism eventually hits a line, which is if somebody hits the criteria for going on PrEP, it's probably worth a shot. And it's just important to have very clear counseling that PrEP's protection is incomplete if one is not taking it correctly. So one of the areas that people always talk about are methamphetamine users. So anecdotally speaking, and in some of the data, all of my meth users who are on HIV meds are undetectable. Just saying. So though they're hectic in lots of other ways, they manage to stay on meds. So if people are motivated to do PrEP, a study in San Francisco in the STD clinic showed that people who started PrEP in an STD clinic and they were pretty hectic in their lives had a 90% adherence rate that was backed up by drug levels. So if you're motivated to do it, it's worth starting.
I just have one question.
Yes.
You mentioned taking an initial BMP to check renal function and to check for proteinuria, and then you mentioned again at the first visit, but then it was never mentioned again.
Yeah.
How frequently are we doing that, or are we doing microalbumins to check for proteinuria?
I think I was going so fast, but the way that I did say it, but I'll say it again. So it's visit one you get a baseline at visit one of a BMP. 30 days later, another creatinine check. 3 months creatinine check. Once every 6 months from then on out for creatinine, and an annual urinalysis. No microalbumin necessary, just a normal UA. The flags are normoglycemic glycosiuria and proteinuria that's unexplained, which could be a harbinger of side effects of tenofovir. If you were to see that, the answer is to repeat before you make any sudden moves.
Quick question. Is it covered by Medicaid, and how much does it cost for
New York State Medicaid, it's a yes. It's covered by New York State Medicaid. Outside of New York, it may not be a yes. About $1,200 to $1,500 a month is what the drug costs. I also say that right now we're thinking about oral PrEP. Remember that within 2 to 3 years, there's going to be either rilpivirine or cabotegravir, which will be injectable. There will be a 3-month depot. And so that's coming.
I was wondering if you could just briefly talk about, from a public health perspective, how the shift to focus on PrEP may be decreasing a focus of universal treatment access?
Yeah, in the US, that's not going to happen. At least not in New York, it's not going to happen. Because the services for people living with HIV and the sort of mechanisms for ensuring them are great. The streams of funding for PrEP and for treatment are very different. So the expectation is that there won't be a shift in focus, it's just going to be a blending of the focus. They're really in a state where there's Medicaid expansion and where ACA is really taking off. We're going to be using all of those tools to bring HIV negative people to care, just as we were doing it for people living with HIV. In resource limited settings, I mean, not that we're not resource limited, but in very resource limited settings, this is a way more interesting conversation of, if you only have so much tenofovir or emtricitabine to treat people for HIV, will you prioritize treatment or prevention? And the answer is going to be treatment. So there will be resource allocations decision made away from PrEP in certain environments where treatment is more important. Great question. All right.
Thank you, Demetre.
Great, thank you so much.
Thanks. Let me just, I had one comment about being family physicians and adherence. This is actually one condition where our role as public health providers really becomes important, because sometimes I've found unlike statins where your behavior only affects your own health, this is behavior that affects people that you potentially could care about. You know, it's like tobacco smoke and secondhand smoke. So I think there's an opportunity for those of us in family medicine who we take care of relationships, that sometimes thinking about, you know, it may not be somebody whose own harm reduction is going to motivate them, but the harm reduction of people that they're engaging either in monogamous relationships with or even anonymous sex. I mean, there's a real public health role that we can play in terms of family physicians, and Thank you, Demetre.
No,
This was
thank you so
great.
much.
This was really great.